All right, welcome to part B of clinical psychology, and that is the treatment of psychological disorders. And we'll get started right away. All right, so there are parts of treatment, and we kind of want to understand how they're connected together. There's several different kinds of treatment that we're going to be talking about, and a lot of them are based on the different schools of psychology. So think of those, the psychodynamic, the behaviors, the cognitive, and so forth. So what we want to do is look at what are the things that are common, first of all. And so obviously there's some pretty simple ones. There's a client there's a patient and a therapist, right? So, I mean, without those two things, you probably don't have much of a treatment program. And the client-therapist relationship is, I won't call it unique, but it is professional, right? And so there's some pretty I won't call them strict, but general guidelines that maintain rules in the relationship between the client and the therapist. And those can change depending on the kind of therapy or the type of the school of psychology that's being relied upon. So obviously a psychodynamic therapist would have a different sort of a relationship than, let's say, a cognitive behavioral therapist would, one who's just trying to change the behavior or the thinking. So those things are unique, and but each one has its own relationship style. Every one of your every one of these theories or treatment plans is going to be based on a theory about what causes the client's problem. That would make sense, right? And then, of course, you have inpatient and outpatient. Inpatient means that you're in a room, in a hospital, in a center, or like a rehab center or something like that, a specific place where you don't stay at home, where you go and have the issue dealt with at their place. Outpatient is where you go to an office and then go back home again or go to work or whatever else. So that would be outpatient treatment. All right. So there's lots of names: psychiatrists and psychologists, clinical social workers, marriage family therapists. Sometimes they're called MFTs. Some they're called marriage family child MFCs therapists. And so their specialty is relationships within families. Clinical social workers, we have those here at school. And social workers deal with, other people's issues. So we have a social worker here that may have worked with your family or other families to help you with your education and beyond your education. Psychiatrists generally are doctors. That means that they have prescribing capabilities. Well, that's not true. There are some psychiatrists that are not, but they are doctors, and generally have the highest requirements. Psychologists are just, I think, below that. Professional counselors, so a lot of the counselors we have at school here are professional counselors, but they are not they're not psychologists and they're not psychiatrists. That would be another level. You can get MFCC is a master's degree plus, I think it's like 3,000 hours of internship. To be a licensed professional counselor, or like our counselors here at school, you don't have to have that. You just have to have the degree, and I'm sure there is some form of an internship or like a student job where they place you in a school with a supervisor and you learn how this works. Psychiatric nurses, like they're regular nurses, except for you deal with psychiatric patients. They might administer medications. that kind of thing, but they're not allowed to prescribe, and they're not actually there. They need to understand the needs of psychiatric patients, but they're not actually working at diagnosis and treatment other than doing what they're told to do. Substance abuse counselors and pastoral counselors. So all the way down the line, pastors, that's the one that got me interested. I was a pastor and had to do pastoral counseling, and that's why I began, I guess, started going down the road of psychology, because people came with problems, everyday problems, and I just thought it would be, well, one, it was interesting, and two, it was very useful. So all the way down the line, obviously being trained to do pastoral counseling or substance abuse counselors are very defined. And, when you get farther down on the list, actually anywhere along the list, knowing your limitations is important. And when somebody comes in with an issue that is outside of your expertise, let's put it, then you refer. You refer to a different counselor or a different type of counselor. Okay, so let's get going now. Those are basically common things. There are some general features of psychotherapy, and psychotherapy is a specific definition, one-on-one treatment approach. This is not group, so you would not do psychotherapy in a group, right? You do it one-on-one. You're trying to find the connection between a person's past and their current problems. That's generally psychotherapy. Usually somebody who does cognitive behavioral therapy doesn't really do psychotherapy, because their interest is not what's in the past, it's changing the future. So psychotherapy looks to the past and tries to connect it to the current problem or issue. So they're going to go more into thoughts, emotions, and motivations, whereas a cognitive behavioral is going to be much more into the behaviors of what are you doing, right? And cognitive would certainly connect to thoughts. But again, you're trying to change the thoughts going forward rather than worrying about where those thoughts came from. All right. The focus is always going to be on the client-therapist relationship in psychotherapy. It was actually put together, remember, the psychodynamic or psychodynamic approach. It was Sigmund Freud. And it was the id, the ego, and the superego, and the interrelation between that, the conscious, the preconscious, and the subconscious. And so there's always trying to get to the unconscious conflicts that were not resolved. So while Freud had some little things, or not little things, they were pretty big to Freud, but he believed all of the conflicts were tied to your sex drive or your libido. And the pleasure principle, I think, was the other term for it. It doesn't have to be that, but the general structure and the look, what are we looking for, came from this model. Okay, so almost all psychotherapy kind of looks like this. Remember, Freud was a doctor. He was looking into his particular patients were saying that they had problems with hysteria. That's how he labeled it. And it was like, it's kind of like panic attacks and that sort of thing. It's like when you ask somebody why they're so fearful or why they're panicking, they go, I don't know. But it must be something because I'm reacting like that. So, and he's always trying to work through the unconscious conflict. So that takes a special tact, right? So it's the stuff you can't access in your consciousness. Freud believed, basically his consulting room or his office had a couch. He would lay down on the couch or sit in a relaxing position or whatever, and then he would ask you questions. And the idea was to do free association. That is, to kind of like word association. He would say one word, you'd say the first word that pops into your mind. That kind of thing. And he hoped to, by hearing what popped into your mind, to be able to connect that to your unconscious. Where did that come from? Well, you don't know. It just automatically popped out. So free association, resistance, where do you resist? Interpretation. So he would go to those free associations and where you resisted, and he would say, I think this is what's going on. And he looked at dreams. Manifest and latent means, manifest means clearly seen, you know, so when you see a person, that person is who they are in your dream. Latent would be something like you see a horse. Well, what does the horse represent? It's hidden, right? And so they would try to interpret what those dreams and thoughts had to do. Freudian slips are things that you say that could have been true, but you know, it's like a word slips out accidentally, and you go, oh, that's not what I meant, and you change it to the right word. And he would want to listen to what the slip was, what was the mess up, because he would say that's probably in your unconscious or subconscious somewhere, and we need to pay attention to those. So Freudian slips were really important. A transference is the unconscious tendency of a patient to assign to others the present environment. Feelings and attitudes associated with a significant person in one's earlier life, especially the patient's transfer to the therapist of feelings and attitudes. So what they were trying to do is get you to feel something and have you transfer that to the therapist so that they could experience what you did. So again, kind of classical, it's almost made fun of in movies and the ideas, but trying to get the patient, the person being counseled, to access information and responses that they don't know where it's coming from. And so if they can get you to, if you can, as the therapist, can get them to transfer their anger or their anxiety to you, then you can feel where that's coming from and help them in insight, give them insight to the connection to their early experiences or people. All right, so there are, obviously that was the way it started. There are newer variations in psychoanalysis that we call these neo-Freudian therapists. Neo means new, so they started with Freud, but they've changed it and adapted it. So there's ego analysis. Remember, the ego is the reality principle. This is the way that you think people see you, or the way the world sees you, or who's really you, what you want to be true of yourself. And so analyzing that is important. Individual analysis. So they would go more to what's concrete and what's there rather than the hidden unconscious or subconscious. Object relations therapy, interpersonal therapy, and the search for core conflicts. So in psychodynamic psychotherapy, you're trying to figure out what things or what people trigger those emotions, and what is that object connected to, or what is that person connected to. You're trying to find out what is actually the core conflict that's causing this unwanted or undesirable behavior or feeling. All right, so that's pretty much a nutshell of the psychodynamic type of therapy. We're going to move on now to humanistic therapies. Humanists, remember, have a different set of assumptions about problems. All right, and so this is going to sound very different than the psychodynamic. which is good. They should be different. You should be able to compare and contrast these methods of therapy. All right, so the concept of treatment is to allow somebody, here the therapist is not in charge. It's just like you're walking down the road together with another person, right? And they are an equal. They're not going to give you a cure. They're just going to be a partner with you as you explore what's inside, right? They believe that humanistic theory says that everybody has a natural tendency to grow towards health, right? And so if you remove whatever is in the environment that's hindering that, you don't have to tell a person what to do. You just have to remove the hindrance or identify what's hindering, what's causing this, and solve that. And then you will heal, you will grow on your own. Okay? So feel that difference between that and the psychodynamic and a few others, actually. But that's the only two we have on the table right now. Okay, pardon the interruption there. If you sense that, the computer kicked me out, so we're going to keep going and see how we're doing. So we're talking about how humanistic therapy actually treats the therapist and the patient as equals. It's more about the environment. Clients will naturally improve on their own because that's what we do. So this is where hopefully the therapist is going to accept and support, right? This is because if they are critical and giving you negative feedback, it's like, ooh, that's not good. Ooh, you shouldn't do that. Then what happens is we tend to shut down or shut that off. And so what they want to do is a little bit like Rogerian, and that is that unconditional support. Even in things that might be questionable, they're going to try and let you, first of all, identify what's in the environment that's causing that. And they might encourage you to figure out ways that you could separate from that part of your environment. But then actually to grow forward from that, they're just going to leave that up to you because that's what you will naturally do. The clients are responsible for choosing how they'll think and behave. This all makes sense from what I just said. You rely on your inborn predisposition to growth, and it's conscious rather than unconscious. There's a big difference between that and the psychodynamic, and the present is what we would focus on rather than the past. All right. As I mentioned before, Rogers is a big name when it comes to humanistic therapy. So Carl Rogers, I don't know if he invented it, but developed a thing called client-centered therapy. Non-directive means you don't tell somebody what to do. You don't tell someone how to solve their problems. You're genuine, you accept, you feel with them, you listen. A lot of times what a person says, you would say it in other words to make sure that they're apprehending what they're saying, right? You ask them to clarify things. How did that feel? Those kinds of things. And again, unconditional positive regard, and that is you accept no matter what. This is where it gets a little controversial when you're going to a therapist and you go, okay, you're talking to somebody who has serious criminal background, and you're going, oh, that's nice. That's nothing to worry about there. Kind of, and it's like, wait, what? Huh? I would expect some pushback, but that's just. But if you're Rogerian, you remember the humanistic underlying idea is that this person, no matter what they've done, actually will grow if you can take care of the environment that has put them into this position to get them thinking these sorts of thoughts. All right, Gestalt therapy has some basic tenets. So it's a different kind. It's not humanistic, although Gestalt sort of fits with humanistic. There's natural psychological growth, and again, doesn't this sound like the humanists? As long as they perceive and remain aware and act on their true feelings, right? And so this is positive regard for what and who they are. Let's see. So self-awareness. This is where the person walks beside you and looks at your whole life overall. And you might be missing some things. You might say things or feel things as you walk beside them, and they go, oh, look at that. You know, kind of reflecting back what you're telling them. So you prod clients to become aware of their own feelings, things that they might have disowned, urged clients. So this is a little different than Rogers' client-centered therapy. This is where you try to get them to recognize the deficiencies in themselves. It does not quite as positive as the Rogerian or Rogers client-centered therapy. You look for inconsistencies and try to get the clients to say what they express through gestures and body language. So if they tell you there's no problem, but they look like there's a problem, you might point that out to them and have them resolve that to get to, so what actually is real? Do you have some hostility, or do you not have hostility? And so what's the difference? Why is there a difference between the way you're sitting and what you're saying, right? So that kind of inconsistency, those would be key in Gestalt therapy. You're trying to take into account the whole person, including the way they look, you know, their physical attributes and how they're holding their head, and so a lot of body language reading. Clients in Gestalt therapy might talk with themselves, different parts of their own personalities, and that sort of thing. All right, let's move on to behavior therapy. Now, behaviorists, remember, those are the people that when we studied the learning unit, these were people that were talking about behaviors and the connection between behavior and yourself or who you are. So they would say that if you have psychological problems, they were learned. And therefore, if they were learned, you can unlearn them. Not necessarily to focus on those bad behaviors or unhealthy behaviors, or however you want to term them, but it's more about, so what would you like to do? What would you like to behave like? What would you like to have on the inside? So focus on going forward rather than on going backwards. You don't need to look back in your past. It doesn't really matter what caused the problem. What matters is replacing that problem with appropriate behavior, thoughts, feelings, and that sort of thing. So you learn these, you can learn new ones. We call this, well, behavioral and social cognitive. We're going to talk about social cognitive as its own thing, but both of these schools of psychology would go, no, it's more about where you are now and what's going forward rather than what's in the past. Watson, Pavlov, and Skinner ought to be names that you know very well, and you know what they taught. So these are the guys that are at the foundation of the behavioral school. Some features of behavioral treatments. This is where we have productive therapists. That is honest, open dialogue where the client is the client-parent therapist relationship is verbal, visual, that it's open and honest. So you would ask the client, so what are the behaviors and what are the thoughts that you actually are trying, why are you here today, right? There's something going on that brought you to my office. So what is it that I can actually help you with? And so let's work at that. A therapist in a behavioral treatment is going to give you homework. They're going to give you tasks. They're going to give you procedures. They're going to do that kind of thing. And then they're going to monitor you. So you're going to go home, and for 2 weeks you're going to keep a diary, and you're going to do this and you're going to do that. And then you're going to come back, and then we will evaluate how that's going, what's changed. And then we will adjust the treatment. So that's the kind of relationship that the treatment that a behavioral therapist or cognitive behavioral therapist would do. There is behavior therapy, which is based on classical conditioning, right? You want the person, remember, classical conditioning is not the one you think about, it's the one that is autonomic, right? This is like Pavlov's dog salivating. Operant conditioning is different, right? So it depends on, so like if you're talking about a fear reaction, like a phobia or something like that, we're going to try and classically condition you so that if you learned to be afraid, you can learn to not be afraid. And so they would do behavior therapy that would be like that. Behavior modification is where you would actually use operant conditioning, and these are conscious decisions. If I do this, this will happen. And you make a connection between the reward or the reinforcement and the desired behavior that was identified at the beginning of your treatment. And then cognitive behavioral therapy is focused on changing your thoughts that produce the behavior. So all of these things, remember our learning unit. You might want to go back and review that learning unit about punishments and rewards and positive and negative and all of that sort of thing. And then in the classical conditioning, review the parts of that as well. And you'll understand how this behavioral treatment might work. Classical conditioning techniques, which would be counter conditioning. In other words, so again, they think you've learned this, therefore you need to relearn a different kind of reaction. So it can be exposure. This is where if you're afraid of something, they do systematic desensitization. This is getting you closer and closer to whatever it is that you're afraid of, if it was a phobia, right? So you might look at pictures first and then maybe see something from a long distance and then get it closer to the point where the thing that you're afraid of, you're able to learn your way out of being afraid of this. Virtual reality exposure is new. It's where we use these virtual reality glasses, and they put you into situations where you consciously are aware it's not real, but at the same time, your senses are telling you that it is real. And so you can adapt over time to being not virtual reality, but real reality, right? The real thing. Okay, all right. So I just got kicked out again, and I've re-entered, so we'll see. We're going to keep going, so this may be a broken up sort of lecture, but I'm trusting it will do okay. I just get tired of starting over again. So we're going to look at some techniques that behavioral psychologists might use to take care of different problems. So systematic desensitization, I already sort of explained how that works, where you bring somebody closer to their fear. Actually, this is probably one of the most successful areas of psychology. And they're very good at helping people overcome fears. So you can you create a desensitization hierarchy, and that is where you get closer and closer to the thing that you're afraid of, right? So, and you relax, they try to work with you while you're getting closer to these progressively scarier things. And you can use virtual reality. Behavior therapies can include behavior modification. This should all be familiar from our learning unit, token economies. So what's wrong with these operant conditionings? Well, you know, the deal is that once you take away the rewards, especially if you do the rewards under the control of the patient, when the rewards stop, so does the behavior. And if you remember, that's one of the criticisms of that kind of operant conditioning. And so also you have to have somebody, what would you see, overseeing or supervising that. And so you're going to have to, you don't want to live a life where somebody else is actually in control of that behavior. So how do you modify? Well, modeling, remember we learn by observation. That's one of the things. So if you model the behavior that wants to be experienced, then you can do that. Positive reinforcement, and that is providing rewards or taking away unpleasant things as a reward, right? That's negative and positive reinforcement. Probably not going to do punishment. That's not very productive. We're looking for extinction. You have to remember that when you learn this, the behavior that's been learned may go extinct if it's not reinforced occasionally at least and relearned. And the other issue is flooding, and this is one where we talked about learning. So it's not used, except, I shouldn't say it's never used. It's very rarely used, and this is like throwing somebody into the water who's afraid of the water to teach them that they're not going to die. And it's, I don't know, I've never heard of it actually being used in that sense. Somebody who's afraid of spiders, well, you put a spider on them or lock them into the closet with the thing that they're afraid of. Actually, I guess it might work, but they're going to try every other way. And you would actually have to agree to that, which if you actually had that kind of phobia, you probably wouldn't. So it's not going to work. I have a video here, which I'm not going to play because it's not going to show up because it's copyrighted. All right, so aversion conditioning is based on classical conditioning. So this is where something, you know, what you do. So like if somebody wants to quit smoking, you give them a chemical that every time they smoke they become nauseous, right? And so it modifies behavior by producing negative results from that. So it can be very unpleasant, painful, whatever. It is, you know, it's possible. Gambling, addictive drug use, sexual exhibitionism, that sort of thing. Producing some so when you do this, you pay a large fine. When you do this, some negative consequence is the result. All right. So a caveat is say, well, yeah, okay, but why wouldn't you do this? Well, it's really unpleasant and uncomfortable. It doesn't always work with all clients. And the effects are often temporary because the punishments are often, you know, if you can hide the behavior, then you don't get the punishment. And so that's actually not going to teach you a different behavior. It's going to teach you how to avoid being caught or being seen. All right, so how do we apply these punishments? Well, we know punishments. So it actually wasn't what I was thinking it was going to be. So how does punishment work? Well, it's operant conditioning again. It's unpleasant stimulus. It's used after the undesirable response, right? It goes back to your learning unit. Just go back and review those notes, and you'll get this. This is beneficial, it says, for some institutionalized clients. So you would think of the prison population or possibly in a situation where it would be much more difficult for a client to hide the behavior, whatever it is that they've decided needs to be changed. So in an outpatient sort of clinic, you go to the office and you're there with the therapist for an hour or two, and then you go home and you're home for a week. Well, all you have to do is hide the behavior, not confess the behavior, and then so the punishment will be avoided. And so that's one of the downfalls of that kind of thing. So, all right, so we would want to use punishment. When would we want to use punishment to modify behavior? One, it's a really dangerous behavior, and so you need it to stop immediately. You'd have to watch this carefully because, again, it lends itself to hidden behaviors, right? You're going to hide from the therapist or the people that are going to keep you accountable, and punishment. You'd want to do this when all the other methods have failed. And you would want this reviewed by an ethics committee. When you're going to punish somebody, you need to make sure that that punishment is approved and that everybody sees that this is going to be, that this is beneficial for this particular client. Otherwise, it could be construed as possibly, unwarranted, that you're actually torturing the person, that sort of an idea. And the client, you would want the client. And if the client is not able to, so they're not like somebody who has psychotic breaks and is not able to deal with reality, you'd need to get a close relative to agree to the treatment. You only do this long enough to take away the undesirable behavior. Once the behavior stops, then the punishment or the negative consequences should be taken away. And you would want to do this in conjunction with other behavior modification techniques. All right, now modeling, where you would watch the therapist or other people. It can be done in video, it can be done in live, it can be done out, but the client, the person who's trying to overcome whatever behavior it is that's undesirable, what does life look like? What does a person look like that's not exhibiting that behavior that you want to get rid of? What behavior do they replace it with? So this combines live modeling with gradual practice. So this is gradual. So you could do this over 8 weeks or 12 weeks. You go, okay, so here's the goal. Let's look at what that might be modified incrementally. In the next 2 weeks, you're going to do this. In the next 2 weeks after that, you're going to react like this. Social skills training, where somebody is trying to figure out how to be assertive, right? So this is being fearful of another person's judgment or their power in your life. And you go, what might it look like if you actually stood up for yourself, right? That you created your own space and you did it in a socially acceptable way. Maybe you're trying to figure out how to dial it back so that you're not overly critical, or, no, it's not critical, that's not the right word. Overacting, overreacting, let's put it that way, possibly with anger or what you're saying. So you'd go, okay, so how are you going to stand up for yourself and do it in an appropriate way that you can still live in this social situation? Social skills training, teaching people to be more comfortable. Gradually, you don't want to throw somebody to the lions, so to speak. You don't want to put them out there. You would want that to be gradual, getting along with peers, making conversation on dates. There's actually ways that you can learn all of these things. And most of the time we don't do it by, well, we do. Most people are not going to go to a therapist for this unless it's an extreme problem, right? And if it's an extreme problem, they are not able to actually learn on their own. So they need somebody to help them along the way. Assertiveness training, where you need to draw a boundary. You need to say, this is not acceptable. You're stepping into my life and it's not appropriate. So direct expression, this is where you're able to say positive and negative feelings, to stand up for your rights while respecting others' rights. So that's a very nuanced sort of position. So it's not just about I have my rights. You also, when you say that, you realize they have their rights too. So you would want to approach that kind of conflict carefully. Use of I statements. This is really valuable when you're in a situation where you feel like somebody's taking your territory. Rather than saying you're doing this, it's you. You say, no, I feel like this. This is how I see the situation. Then it's not an accusation and other people are able to hear it. It's not, I didn't say that you were making me feel this. I said, I'm feeling this. Right? You see feel the difference there? So this is really good in relationship therapies, marriage therapies, couples therapies, where people are having a hard time discussing whatever the touchy situation is help people to talk in the I, right? Role playing, let's switch roles, right? And so the other person has to play the other person, the person the conflict is with, they have to play the other side. And what you hear is misconceptions, misappropriations, and those sorts of things. Very helpful in helping people get to a place where they can change behaviors that are being destructive to their lives. Let's see. We do group, often conducted in groups. You don't have to do individual therapy for that sort of thing. Positive reinforcement or rewards. So rather than punishments and modeling, now we're going to use rewards. So when you encounter, so think about this, when a child is learning not to throw a tantrum. So every time you go to the grocery store and the child throws the tantrum and you have to take the child out because it's, disrupting business and that sort of thing. You don't want to give in, but you want them to learn not to throw a tantrum. Then the next time you take them to the store and they don't throw a tantrum, you actually praise them or give them a small reward and let them know you notice their behavior and that's actually learning. That's a reward, and they go, oh, okay, that's good. That felt good. And hopefully will reinforce that positive behavior that they have just learned. Schizophrenia treatment. Schizophrenics respond to rewards and reducing substance abuse. So all of these are positive reinforcement potentials that are behavior modification. So we can use token economies. You don't have to give the whole reward at one time, but you need to break the reward down into little pieces. It's like giving people 25 cents instead of giving them $5. So 25 cents is working towards the $5. When you get to the $5, then you can exchange that for something you really want. So it's making the reinforcement small enough and manageable enough that you can afford it, right? And that means something bigger than just that one reward. All right, let's see. Do we use this with institutionalized clients? That means people in prisons, people that are inpatients, people suffering severe intellectual disabilities or other serious disorders. The goal is to shape the behavior patterns that are going to live or persist outside of the institution. If you're using this in an institutional model, hopefully when you leave school, some of the things you learn will take root in your normal everyday life. Extinction is where you want something to go away, possibly fear. That's a common one in phobias. So this is where we talked about flooding, how it's you put them into the feared stimulus and the fear response weakens. All right, and so not very often used. But the goal is to extinguish unreinforced behaviors. Let's see, gradual exposure. So we talked about flooding. Flooding is where it all comes at once, right? And gradual exposure therapy is actually much more common. It's less distressing and pretty common. Let's see. A lot of times panic disorder. So people that have panic disorder, social phobias, OCD, maybe agoraphobia, that sort of thing. So people that have agoraphobia, a lot of times develop it because they have a panic attack, and then they go, well, I'm not going there again, and so they don't go there again, and it reduces the panic attack, and then they have another panic attack, and they go, oh, okay, well, I'm not going to go there too, and eventually their world shrinks down to almost nothing. So you have to expand that and say, well, actually, let's go there and take them. Same thing with OCD, people that are lockers, people that are whatever obsessive compulsion that they have, you gradually expose them to push back against that phobia or that compulsion. All right, we're moving on now to cognitive therapies. So a lot of times today, you will go to therapy and it will be cognitive behavioral because of the connection between what you think and what you do. So cognitive behavioral is common today a lot because their focus is on fixing the problem. They're not concerned with where you find where the problem started, right? They just go, we're going to work at changing your mind and changing your behavior going forward. So when you go to a therapist, a lot of times the insurance companies, because they have to pay for these therapies, are going to, they're going to say, we'll give you 12 sessions. And in those 12 sessions, hopefully the therapist and you can work out some new behavior or new thinking that will solve the problem, right? And so that way they're done. If you went into a psychodynamic situation, it might take years of therapy, and insurance companies really aren't interested in doing that. So anyway, so that to say behavioral. Now we're going to talk about cognitive, and like I said, they throw these together in cognitive behavioral therapy, and but they kind of work together. So we're going to go through this and see what we can find about cognitive therapy. So cognitive behavioral therapy or rational emotive behavior therapy are two terms. It was devised by a guy named Albert Ellis, and he believes that problems are caused by how you think about events, not the events themselves, right? So we're not going to go about changing the environment like we would in a humanistic thing. We're actually going to change your thinking about the environmental trigger or environmental situation, right? And so the process is the client learns to identify self-defeating beliefs. What is it that you're thinking that causes you to react in such a way that you're acting out or you're feeling in a way that's not good for you? And the reason why we know that is because you're here in this session, right? It's like that would make sense. So the client here is supposed to learn to first identify and then recognize the thoughts and how those thoughts can cause problems, And then the therapist helps the client replace those harmful thoughts or feelings with more realistic ones using modeling, encouragement, and logic. So this all makes really good sense. So they try new ways of thinking in everyday situations. So this is pretty, you can see it's not about what caused this problem. We don't care if it's a biological problem or something in your past or some hidden memory or you were mistreated when you were 6 or whatever. It doesn't matter. What matters is we're going to try and change your reaction to life that seems to be causing problems for you right now. All right, so cognitive restructuring is new thinking patterns replacing upsetting thoughts. So cognitive restructuring, that's changing the thinking that you're going through. Self-instruction, this is where you can talk to yourself internally or externally, I guess, although probably internally would be better in a public setting. So when you start to recognize those thoughts or those feelings, you begin a dialogue where you can actually re-educate yourself to the situation. And then this is where you know probably at this point where you struggle, when you start having those feelings, when you start reacting or acting out. So just think about those stressful situations and then practice. You don't even have to be in the situation. You can just imagine the situation and then practice how it would be working through that. So remember that Albert Ellis was the one, it's called, because rational emotive behavior therapy is really long, it's called REBT. Okay, so to try and calm irrational thinking and challenge the way a person does think. So you see here Peanuts, Linus and Charlie Brown are talking. Life is rarely all one way, Charlie Brown. You win a few and you lose a few. Really? Gee. So Charlie Brown, you know, is the quintessential loser. He always loses, right? So this is a new thought. Hey, maybe you win and you lose. So that would be REBT. Beck had cognitive therapy for depression. So these are cognitive distortions. Some people, you know, there's a reason for depression, and it's when bad things happen. And so some people look at things and they go, oh, this is a massive catastrophe, and it turns into depression. And the reality is all you have to do is reframe the catastrophe so that it's seen as maybe not all of that catastrophic, right? It's people that have all or none thinking. It's like the world's coming to an end. No, it's not coming to an end. You had one bad thing happen. Look at you had 9 other good things happen, right? So cognitive distortions that can lead to depression. If you can get the person to think differently, the idea is that the depression will be relieved. Sometimes we personalize things. It's all about me, right? This person did this, and this caused this to happen to me. And I go, well, no, that's actually not what they were doing. They were actually doing something else. It had nothing to do with you, right? So what's the process of this? You identify cognitive distortions, just like previously you identify cognitive conflict areas, all right? So cognitive distortions, you identify them, and then you develop ways to treat those cognitive distortions, right? So now it may not be a cognitive distortion. This is where the therapist probably help you identify them. So, you know, so once you identify it and believe it's actually a distortion, then you have to figure out, so what would it be like if you did this? What would it be like if you thought that, right? It's testing out. This is where the client, you can go home. give me 3 different ways that you could have responded to this situation. You know, and so this is where the person goes home and they think about it on their own. So challenging and reducing false beliefs, right? And so this is where the idea of cognitive behavioral therapy is tied to depression. Usually you can't deal with somebody's depression directly, but this is the idea that the depression is directed or source in your thinking, right? So if you change the thinking, then the depression will go away. Reorganizing, connecting, correcting distortions. We already got that. All right. These are just some statements about REBT, or cognitive. So Beck's therapy is more about optimistic ways of thinking and reducing self-blame. It's so again, this is all in the client's mind. It's like how to reframe things, how to see things from the better light rather than the negative light. Cognitive restructuring combined with other things like social skills, anxiety management techniques, all of these to develop confidence. And once they're learned, then the client can move on with their life with less problems. Mindfulness is a cognitively based sort of therapy. There's a lot of information out there about mindfulness. They do this at the district and at school to try and get you to put yourself in a positive state of mind so that your learning goes better. Meditation, monitoring, you know, where a teacher has you come into the class and just sit and contemplate and calm yourself and then deal with whatever issues that are going on. And so we actually find this is maybe not as structured. It doesn't have to be a therapist. This can be done in a therapeutic situation where a therapist actually does this. But we can use smaller versions of this even in our everyday lives. And the idea is to promote positive emotions. And that actually, we do find, helps you cognitively, which is why a teacher might do something like this, right? They say, well, how are you feeling today? Express those emotions. How could we reframe that? What can we do with those things? Maybe list the things that went well each day. All right, so I have here a chart. I'm going to leave it up for a moment or two. So this is cognitive therapy techniques. So if you look at here on the left, there's revealing beliefs, testing beliefs, and changing beliefs. Now, beliefs is another way of saying what you think. So how do we find out what you really think? Can we test what you think? In other words, is it actual or is it imagined? And how would we change those beliefs? All right, so rather than me reading all of this, I'll leave it up here. If you want to, you can pause the lecture and you can read it over time. You might want to take a few notes on this. So these are cognitive sections of cognitive therapy. So these are the therapies that we've talked about. We haven't talked too much. We will talk about group or family therapy here in a little bit. But there is psychodynamic, client-centered, that's humanistic, behavior, and cognitive, and then cognitive behavior. And again, this is, I'm going to leave this up for a few moments. If you'd like to look it over, take notes. You want to be able to compare and contrast these therapies. So as you've taken your notes, now review them by going over this chart and going, okay, do I remember this? Do I remember that? Okay? So I want to get through some types of therapy here that are not tied to the schools, but they're kinds of therapy. So we've been talking about individual therapy mainly, but it's not always individuals. All right, so there's also group, family, and couples therapy. And how is that different from individual? So group therapy, obviously the therapist sees clients and they interact. He sees them interact with other people. So it can be, the group can be people you do know or don't know, people with a common problem, as in an AA group, or possibly something like that. Some anger management sometimes is done in group, where other people that have similar issues so they can share their stories. Part of the goal of a group therapy is understanding there's other people that struggle with the same thing you do. This actually helps you go, okay, I can face this now. I'm not the only one in the world. And other people in the group accept you because you accept them because you understand their issue like they understand your issue. Clients learn from each other. They're more willing to share what's going on because they would feel like they won't be judged as harshly or ostracized or something like that because everybody in the room has the same problem. And this is where you can actually role play in groups and you say, let me try this out and see how that would work, right? So group therapies are very effective that way. There's also self-help organizations. They a lot of times work in groups. Alcohol, drug addiction, sex abuse, sex addiction, overeating, bereavement, somebody's died, they're grief groups that meet together, compulsive gambling, even schizophrenia. So it's hard to assess because it's hard to get data. These groups generally don't keep notes as if you would in individual therapy. Your therapist will probably keep a file on you and they'll take notes, and to be able to see progress and maybe they remember hearing something but they don't remember the details. They'll go back and look at their notes. Doesn't happen in self-help organizations, so it's hard to get data as far as how helpful it is and what actually happens there. But seems to be, I mean, they keep happening. They've been going on for decades now, so it's evidently perceived to be effective, right? Family and couples therapy. There. Let's see here. So sometimes the problem is the dynamic of the family, and sometimes the issue may, a lot of times this happens where one person comes in for therapy and they talk with the therapist, and the therapist goes, it really is a systemic thing. It's part of the system of your family that you're reacting to. And yes, it is a problem for you, but it has to be dealt with as a group. And so they'll bring in a couple or they'll bring in the whole family at some time. Sometimes you go in for family therapy and they go, well, okay, we need to deal with each of you individually before we can deal with the family system. But in problems that aren't as severe with an individual, sometimes it is just the dynamics of the family and you need to work with them on communication, almost always communication patterns, right? So like, anyways. So the deal is to improve communication, and so they do that there. So what are some rules for good communication? So if you watch people that you go, wow, they really are able to communicate, you can, or it doesn't work when you try to communicate in a family, as a family or a couple, then sometimes just observation is good. Write down rules that would help people communicate well with each other. Things like we talked about earlier where you use the I instead of you, right? And you rephrase or paraphrase what a person said. You repeat back to them what they said, because a lot of times the communication gets messed up as it goes from your mouth to their head. They actually hear something that you didn't say. So that's really good communication possibilities. And share your rules with the class. So this was an in-class exercise, which we're not going to do. All right. Now, here are some rules that are good for communication. Always begin with something positive. So that's always a good thing. And these are all good. I'm not going to read through them all, but I'm going to leave them up for a few moments. It'll give you time to get to the pause button, and you can pause it and then read through these. I think they're very helpful, and there is nobody that can't learn to do these things better and communicate better. And that is where we're going to stop with this lecture. Finally made it through with 4 times getting kicked out. And I will be talking to you soon about evaluating psychotherapy.